I'm Harriette Van Spall, Associate Professor of Medicine and Cardiologist from McMaster University, and I'm so delighted to have with me Professor Alexandre Mebazaa, who is Professor of Medicine in the University of Paris, Director of the INSERM Unit, and Chair of the Department of Anesthesia and Critical Care in Paris. And we are here at AHA 2022 to discuss his fabulous STRONG-HF late-breaking clinical trial. Welcome, Professor Mebazaa.
Thank you, Harriette, for this invitation.
I'm so excited about your trial because we have struggled with the implementation of evidence-based medical therapies for our patients with heart failure. And across jurisdictions, these life-saving therapies are underutilized for a variety of reasons. You led an implementation trial that tested a novel strategy to optimize therapies. Tell us about your intervention and how you were inspired to devise it.
In fact, the initial idea was rather simple. I thought, why for chemotherapy, if you have someone going to see her oncologist and they discover that they have a cancer, and usually the oncologist will say, next Wednesday, you come, we give you a full therapy, and here is a small card. If you have any infection or fever or whatever, you just call and you come and we take care of you. Why oncologists can succeed to have this, and why for heart failure, we have the right therapies. We know the dose that we should give to heart failure patients, but we are not giving it just because there is this people or papers or textbooks saying that is maybe unsafe, or there is a safety issue giving those drugs. Then really, I thought, okay, let's do exactly like for a cancer, and let's give the full therapy immediately, and then we take care of the safety issue. And the idea was to do it after acute heart failure. Why? Because after an acute heart failure episodes, my group published many papers showing that regardless to the country, regardless to the continent, there is always the same story. When patient is discharged from an acute heart failure episodes, first, the chronic heart failure medications implementation is very low. Mm-hmm. And we know that the readmission rate is very high. We recently published a paper with 15.5 million acute heart failure over the last 30 years. The readmission rate is exactly the same today as in 1980, around 50% over 1 year. And the number of deaths slightly improved over years, but we are still around 10 to 20% mortality rate in the year following acute heart failure. Then I thought, okay, here, after an acute heart failure episode where the number of events is very high, we need to do something, and the something is to implement the drugs as quickly as possible.
Tell us about your intervention.
The intervention is rather easy to understand. The patient has an acute heart failure. He, in the first hours and days, he's still dyspneic, and we give him oxygen, we give him diuretics to try to decongest. And after a few days, the patient is really stable hemodynamically. And then there is an opportunity, before his discharge, there is an opportunity to start the implementation of heart failure therapies. Then how are we going to do it? We first looked on patients who are really congestive. Then we took BNP level that was still high just before being discharged, and patients who are really still having a lot of fluids in their body. And then we decided for this intensive arm, with intensive group, we decided to give half of the dose of beta blocker, ACE inhibitor, and spironolactone before being discharged. And then we had following visits every week At week 1, we tested the half doses given before discharge were well taken by the patients and no safety issue. We were measuring several parameters. I will come to those parameters in a minute. But the important step is week 2, exactly 2 weeks after being discharged, the physicians has to increase the 3 medications to full dose, 100% of the dose that is recommended by guidelines: beta blocker, ACE inhibitor, and spironolactone. And then the patient will come 1 week after this big increase in the medications, which means week 3, and then another visit at week 6, and we were seeing the patient at 90 days. In the other arm, the usual care arm, we were doing exactly the local practice, which means that the patients, when he's going to be discharged, we were writing a report, and the patients were sent to the physician or cardiologist in town, his own cardiologist, who usually takes care of him. And then we were seeing this patient at 90 days. And for the 2 arms, between 90 days and 180 days, no special visits. And the primary endpoint was at 180 days. And to summarize, several visits, 3-4 visits after discharge. And at week 2, the patients should be at a maximum full dose for beta blocker, ACE inhibitor, and spironolactone. And during these visits, and this is very important, is usually, even in my practice and in many people's practice, during the visit, we did not know exactly what to do. And here we had a full procedure. You should first do a biological exam, potassium, creatinine, natriuretic peptide, NT-proBNP, hemoglobin. Then the patient was doing this early morning. And then when the exam comes, the patient has the visits where clinical exams, we look on heart rate, blood pressure, whether there is edema. We see the results of the biological exams. And then if it is week 2, we increase the medications to full dose. Then we have 2 things, we have 3 things even. We have when should we increase the medication, the pace of the visits, and what the visits should consist of.
Fantastic. And who are the clinicians providing care in the intervention group?
In the intervention group, there are only cardiologists and mostly heart failure specialists. And we took centers where we have a heart failure clinics, and those are cardiologists who are usually taking care of heart failure patients.
Fantastic. Tell us about your baseline characteristics and study population.
In fact, it is a rather classical patients. I mean, it's really very similar to trials or cohorts studying patients with acute heart failure. Then it's a little bit higher than 60 years old, high incidence of atrial fibrillation, high incidence of diabetes. To be included, the NT-proBNP before discharge has to be higher than 1,500 picogram per milliliter of NT-proBNP, and it was much higher than that. Blood pressure was a little bit higher than normal. Heart rate was a little bit higher than normal. Then really nothing special compared to the patients who are included in all acute heart failure trials and patients who all of us were seeing in our daily practice.
And what was the median LVEF?
It is a very good question, because we decided to not look on the left ventricular ejection fraction. We're taking the patients regardless to left ventricular ejection fraction. And interestingly enough, at the end of the study, we had 2/3 of the patients who had a left ventricular ejection fraction below 40%, and 1/3 who had a left ventricular ejection fraction that was higher than 40%. And 1/3 preserved ejection fraction, 2/3 had a low reduced left ventricular ejection fraction.
Any exclusion criteria?
Rather, very few exclusion criteria. The main inclusion criteria, as I told you, was acute heart failure patients who were not who had only one medication, either beta blocker or ACE inhibitor to start, high NT-proBNP level, but very few exclusion criteria.
Okay, so hyperkalemia, for example, was not excluded, or hypotension. They were all.
Yeah, we paid attention because we knew that we are going to give a full dose of beta blocker and ACE inhibitor. Then we put thresholds in blood pressure. But again, patients, which are a little bit de novo heart failure patients, who were not well treated, those patients had a systolic blood pressure higher than 120. Then for those patients, giving a full therapy did not change so much blood pressure. And in fact, we saw some episodes of hypotension, but the decrease in blood pressure in the intensive arm compared to the usual care arm was only a few millimeters of mercury.
Right. So tell us about your primary outcome and the results of the trial.
The primary endpoint, to try to be as clinically relevant as possible, in addition to try to match safety and efficacy, the primary endpoint was heart failure, readmission for heart failure, or all-cause mortality at 180 days. And we saw a very marked reduction.
Fantastic. That's very clinically relevant. You know, many argue that you could have picked surrogate endpoints like medication doses, but I do agree that a clinical endpoint that is meaningful to both patients and the healthcare system is important. And so what was the treatment effect on this primary endpoint?
The relative risk was 0.66, then it shows you that really it was dramatic. Now, probably it would have been even more dramatic if the endpoint was longer than 180 days, but we really, the concept of the trial is to try to show that we can increase very quickly the implementation of the drugs, because everybody agrees that if you combine beta blocker at a high dose, ACE inhibitor at a high dose, and spironolactone at a high dose, at the end of the day is going to have a clear benefits on any outcome. But our idea was to show that really in the first 180 days would not have a big safety concern, and which was the case. We had really a few adverse events, mostly hyperkalemia, worsening, and in few cases of kidney dysfunction or hypotension. But and we had no adverse event that were really fatal or anything really severe. And at the end, yeah, as we said, the primary endpoint was clearly in favor of the intensive arm, and it was so much in favor of the intensive arm, the DSMB decided to stop the trial because they felt it is unethical to keep having patients in the usual care arm. And it shows, by the way, what maybe we didn't realize for years, that I come back to my analogy with cancer, that probably heart failure patients that are not treated are like cancer. They are worsening day after days and month after month. And clearly it's probably not ethical in patients with a clear heart failure diagnosis. It's not ethical to keep those patients over months without being treated. And even myself, for years, I was thinking, okay, if it's not treated today, we can wait 2 or 3 months. At the end of the day, we can manage to have him at full therapy. But in fact, what I didn't realize is that for all the months where the patient, because we had a busy clinic, because we couldn't see him, because many things, during all those months, he's clearly deteriorating.
Tell us about the drugs and the dosing achieved in the intervention versus the usual care group.
Let me start with the usual care group. At 90 days, if we see only the medications at 100%, for beta blocker and ACE inhibitor, it was less than 5%. Less than 5% of the patients in the usual care had either beta blocker or a RAS inhibitor at 100%, less than 5%. In the intensive arm at 90 days, were close to 50% for each of the two categories. And now, if we look even at the larger range of dose, going, let's say, from 51% to 100%, we can see that in the intensive arm, more than 80% of the patients had between 51% and 100% and had at least half of the dose to full dose. But again, only looking at the full dose, close to 50% of the patients at 90 days had a full dose of beta blocker and ACE inhibitor. And interestingly enough, this 50% of patients had this full dose at week 2. And the physicians, week 2, decided, in fact, there was a turning point at week 2. And this reason why I think that there is still a room to improve even more than 50%, because if you see in the paper, it is interesting to see that for all the medications, between week 2 and 180 days, nothing changed. Then it's really a psychological thing happening. If we give implementation procedure to the physician, he's ready to follow, you give him all the safety concerns, but after week 2, he's happy to put the patient at 50 or 100%, because we said that the dose cannot be below 50%, which was, as I told you, in more than 80% the case. Then in fact, that dose will be the dose that we find at 180 days.
Now, do you have the capacity, do you think, in your healthcare system? Actually, this was an international study, so not just your healthcare system, but some might say, do we have the capacity to see patients so frequently and with the clinical expertise that heart failure physicians offer across healthcare systems? Is this feasible? Is this implementable?
Yeah, it's a very, very good question. I think what is important with STRONG is to show that the concept works. I think we were looking for years on a recipe that helps safely and efficiently to implement a maximum of heart failure therapies at the maximum dose. And I think this, I guess, STRONG achieved this. Now, indeed, there are several visits, and the question that will be raised in the next weeks, but am I able in my heart failure clinics to have 4 visits in the first 3 months for a patient? My answer is yes. My answer is yes, because in the heart failure clinics, when we are asking a patient to come back, there is no special procedure. Some you tell them to come back in 3 months, another in 6 months, and you don't know why, in fact. And I think maybe in heart failure clinics, we should now, with a STRONG trial, we should focus on the first weeks after being discharged from an acute heart failure episode. And maybe we should now rethink the way we are asking the patients to come back to the heart failure clinics. Because if the patient comes in the first weeks, and if at week 2, you can already succeed in close to 80% of the patients to be between 50 and 100%, then my question is, why do we see them again before, I don't know, 1 year or more, because they are optimally treated or not far to be optimally treated? Then I think we just need to rethink the way we are doing our heart failure clinics. And my second answer is that maybe those visits do not necessarily, all of them, be done by a cardiologist. I think the safety visits can be done by a nurse who knows how to interpret biological tests, who know how to examine a patient and refer to a cardiologist, but cardiologists do not necessarily need to be there. Week 2 is an important visit. This visit at week 2, really, it has to be done by a cardiologist who have all the parameters, sees the patient and decide whether he can give the green light for a full dose. But the visit at week 1 and in the following weeks could be done by a heart failure nurse with, I guess, with no problem.
Fantastic. How do we translate this to clinical settings, right? That's usually where the main gap lies. And I think it's the philosophy that the mortality in heart failure is higher than in many cancers, but we have taken it with a grain of salt and not with the urgency that our patients with malignancies receive, and that we need to allocate resources to this type of intervention. We seem to have no trouble offering device therapies that have nominal treatment effects, medical therapies that might not have large clinical benefits. And we know some of the therapies now that do offer benefits. So devising systems of care to implement them are well worth our tax dollars. Thank you for the work of running this trial. I know how hard it is to run implementation trials and to get our colleagues to change the way they deliver care and book patients to see them. Congratulations on your Lancet publication. That's fantastic news. And I look forward to being in the audience and watching your presentation later this week. Thank you for joining us, Professor Mebazaa.
Thank you very much.